Hello everyone. Thank you, Rehabcon organizing committee for this opportunity. So I will be speaking about management of global brachial plexus injury. So this is how a child coming to us. So you can see the right upper limb, only some abduction is happening there. There is another child. So I will show you the results. So when they come to us, they must have already searched the Google about this brachial plexus injury, and they must have gone to all the specialists and come to us for our opinion. So after a pan plexus injury, just suppose all the nerve roots are avulsed from the spinal cord, okay? So in the brain, the cortex area, it's a black hole. The brain doesn't know there's a limb. If left is affected, the right motor cortex, sensory motor cortex area, nothing is there. So the brain doesn't perceive a limb is there. So there are, as Dr. Vinu said, some false positives also, like 20 muscles control the shoulder, there will be a conducting neuroma. Some axons will be intact and some movements are happening. So people think, okay, my child is improving, why he needs a surgery? And hand function may recover first. So that is non-anatomical recovery. If a brachial plexus is recovering, first shoulder, elbow, hand. It should happen in that order. Otherwise, definite there is an injury. So as Dr. Vinu said, we depend only on clinical examination because in all the 100% cases, which by clinical examination we decided that there is need to surgery. All the cases there was a hard neuroma. So, and as Dr. Vinu said, it's very difficult to do an MRI for a 3-month-old kid. You need general anesthesia, so we don't do that. So, if a pan plexus child come to us, what are the options? So, when adequate routes are not available, if on exploration, if you have C5, C6 roots, okay, you can graft from that available roots. If no roots are available, the donor nerves are spinal accessory nerve you have, phrenic nerve you have, intercostal nerves. But in children, we don't take phrenic nerve. If you take one phrenic nerve, the child will be ventilator dependent. And if you take intercostal nerves, there will be some development of the hemithorax will be affected. So they can be taken in adults, but in kids, definite no. So you are left with only spinal accessory nerve, extra plexus. Then comes the option of contralateral C7. I don't know whether you are aware of contralateral C7 transfer in brachial plexus injury. So it has been proven through studies. You can safely take contralateral C7. Actually, it was done in adults initially. So in India, we were the first team to take the contralateral C7 in kids. So this is the C7 root contains up to 40,000 axons. So the spinal accessory has 1,600 axons, intercostal 1,200, phrenic 3,000. So our aim is to reconstruct the plexus to the maximum as in anatomy. So, and nerve transfer, invariably distal spinal accessory to suprascapular. And when we reconstruct the nerves, it will be like anterior division of upper trunk for the flexion of elbow and posterior division of upper trunk so that you get the triceps, axillary nerve and wrist extension. And for the hand, lower trunk. So this is our paper published in the Asia Pacific Journal of Hand Surgery regarding contralateral C7 transfer. So this can be brought to the injured side through a subcutaneous route or the retroesophageal. You can see the esophagus and the contralateral C7 is dissected and brought to the injured side so that it can be connected to the injured nerves. So this is how it will look like. So it's a technically challenging procedure. Only 3 centers in the world are doing this. You can if you brought it retroesophagally, the length of nerve graft will be reduced maximum so that early recovery, regeneration happens. So, and you can use more number of cable grafts so that you can neurotize more number of damaged nerves. So, this picture. So what happens when a contralateral C7 is connected to the injured nerve? We know that our right cerebral cortex controls the left hand, left cerebral cortex, right hand. So in a right-sided injury, you are taking left contralateral, left C7 and connecting to the injured nerve. That is, in future, after surgery, his right cerebral cortex is going to control his right hand. So how this will happen? So this happens wonderfully in kids, children, because of the term called cerebral plasticity. So in kids, their brain will adapt to any surgical changes we make. So these are some connections, intercortical connections developing in the brain. And the lower down picture with repeated physiotherapy, targeted therapy and all, that black area which I showed in the first initial slides is coming down. So this is a picture of functional MRI showing activation of both brain cortex when the child is doing, like suppose this left C7 is transferred to right C7, right limb, injured limb. So the child will be trying to, when he grasps the left limb, this nerves are, injured nerves are activated. So the first child, she presented at almost 9 months. Only one root was present, that is T1. So what we did, nerve transfer, and the contralateral C7 was connected to C8, T1 is intact, and anterior division and posterior division. So the results at 2.5 years, right is affected, abduction, this is the triceps, wrist flexion, finger movements. So we tell the parents to just enclose the normal limb and encourage the child to play with toys with the injured limb. So at almost 4 years, this is abduction and external rotation she is doing. Remember, all 4 nerve roots were avulsed in this case. So holding a cylindrical object, she is trying to write wrist extension she is getting, but when she tries to write, wrist flexion is more happening. Wrist extension is happening. Finger movements and wrist flexion. The other child, in this case, 3 upper roots were avulsed and the lower roots were fibrosed. So we had to just neuralize just release it from the fibrosis. Then it will conduct. 2 years post-op. Triceps, wrist flexion, hand movement, finger movements. Now I will just brief about the pan plexus management in adult also. Again, it's a contralateral C7 transfer, which is the best we can offer. So it's a Wang procedure done in China. So in this, the contralateral C7 will be same. It will be without any graft. It will be tunneled retroesophagally, and the lower trunk is coapted directly, no nerve grafts. And the phrenic nerve can be taken. In adults, it can be taken, and that will be connected to posterior division of lower trunk. So that is true for the axillary and this triceps function, and distal spinal axis to suprascapular, and biceps branch of musculocutaneous nerve. And humerus will be shortened by 20%, and it will be fixed in 15-degree external rotation. So this is the induction physiotherapy, activating the phrenic nerve. So almost. This is a wrist finger extension we are getting. Last videos, ma'am. So right limb was affected. So after this contralateral C7 in adults, only problem now we are facing is the wrist and finger extension. That is a problem still now. So we are doing wrist arthrodesis and some FCU to extensor tendon transfers to improve the function. But that part we are still not happy. We are not. No one is getting in the world. So this, but being this is the best procedure. So this is another patient. See the biceps is how powerful it is. So take home message, clinical examination, most relevant, early surgery, better results, contralateral C7 root, it's a ray of hope in pan plexus lesions. Thank you.
Thank you, Dr. Ajay. That was an excellent presentation, and you have demonstrated very good results. So we'll have some discussion later. And
okay.
Next we call upon the last presenter, Dr. Ravi Shankar.